Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome, everyone. This is Rick Ferraro, Cardiology Fellow at Johns Hopkins Hospital and co-chair for the CardioNerds Prevention Series. We are thrilled for today's episode, the first in a series focused on SGLT inhibitors. Today, we'll be focusing on the biology of SGLT and its inhibition. I am joined today by our co-chair for this series, Dr. Gurleen Kaur, Cardiology Fellow at the Brigham and Women's Hospital, as well as Director of the CardioNerds Internship. Thank you so much for being here, Gurleen. Great to see you.
Thank you so much for that kind introduction. We're so excited for this episode, and I'm really happy to introduce our fit lead for today, Dr. Sahil Jhumgawala, who is currently a cardiology fellow at the University of Miami, as well as CardioNerds Academy faculty. So excited to have you here today, Sahil.
Gurleen, thank you so much for that kind introduction, and I'm so excited to learn more about this topic. It is my distinct pleasure to give our final welcome for today's expert discussant, Dr. Katherine Tuttle. Dr. Tuttle is Executive Director for Research at Providence Healthcare, co-principal investigator of the Institute of Translational Health Sciences, and professor of medicine at the University of Washington. Dr. Tuttle earned her medical degree and completed her residency in internal medicine at Northwestern University School of Medicine, followed by a fellowship in metabolism and endocrinology at Washington University in St. Louis, and a nephrology fellowship training at University of Texas Health Science Center in San Antonio, Texas. Dr. Tuttle has published over 250 original research contributions and served 2 terms as the Associate Director for the Clinical Journal of the American Society of Nephrology and the American Journal of Kidney Disease. Dr. Tuttle is also steering committee member for the CardioNerds-supported ZEUS trial, testing interleukin-6 inhibitor ziltivekimab for secondary ASCVD prevention. Dr. Tuttle, thank you so much for your leadership and support of the CardioNerds Clinical Trials Network and for joining us today.
Well, thanks to all of you. It's really a pleasure to join you and to have a discussion about this super exciting topic that really cuts across cardiology, nephrology, and diabetes.
Thank you so much, Dr. Tuttle. And with that, let's just dive into today's discussion. So we'll start off with our case of Mr. Ronald Neff, a 58-year-old man with a past medical history of obesity, type 2 diabetes mellitus, and heart failure with an EF of 32%, who comes into the clinic after a recent heart failure exacerbation. His current medications are metformin, carvedilol, sacubitril valsartan, and spironolactone. His relevant laboratory values are a hemoglobin A1C of 7.8, creatinine of 1.3, and GFR of 48. Dr. Tuttle, how would you approach optimizing Mr. Neff's medication regimen, and what is the evidence supporting indications for this patient to start an SGLT2 inhibitor at this visit?
Well, clearly, SGLT2 inhibitors are the fourth pillar, not only for heart failure, but for chronic kidney disease. He has both. One of the things I'd really like to know is what his level of albuminuria is, as the urine albumin to creatinine ratio, because when we think about risk-based strategies, in addition to conventional cardiovascular risk factors, we also now recommend looking at eGFR and albuminuria, for example, in the new PREVENT equations. But that said, this is enough for me to start an SGLT2 inhibitor on the basis of heart failure alone. Also, even taking into account the CKD angle, we know from EMPA-KIDNEY that even in patients without an increase in albuminuria, if GFR is low, there's broad benefit across cardiovascular and kidney outcomes. So clearly, he needs the fourth pillar added to his regimen. His A1C is a little higher than I'd like to see it. Ideally, we'd like to see the A1C less than 7 to reduce risk of diabetes complications, heart and kidney, but also from the standpoint of thinking more holistically about retinopathy and neuropathy. The SGLT2 inhibitor will have only a modest glucose-lowering effect, particularly when GFR drops below 45 and he's close to that. We see an attenuation of the glycemic efficacy, although efficacy for heart failure and CKD progression are preserved. But that said, I think that it would be prudent to start the SGLT2 inhibitor and then reassess him relatively soon. Again, from a clinical standpoint, from a heart failure standpoint, but also reassess risk factors. So for example, if the A1C is not coming down, we may add another agent. If he has persistent elevated albuminuria, we might do something else too.
Thank you so much for outlining your logic there, Dr. Tuttle. Now, how about we dive into the biology and mechanisms of SGLT inhibitors, including both their direct and indirect effects? We know SGLT2 inhibitors were initially developed as antidiabetic agents. So, to get us started, Dr. Tuttle, can you please share with us how SGLT2 inhibitors improve glycemic control?
To be honest with you, this goes back many years. And in fact, in 1987, along with Dr. DeFranzo, we gave fluorescein to diabetic rats. And initially, the goal was to reduce glucose without raising insulin. And we were doing physiology studies and we're trying to prove the glucose toxicity theory that you could lower glucose without raising insulin and show pancreatic preservation. But that said, Ralph and I were also nephrologists. And we had a lot of discussion about what would happen with regard to kidney hemodynamics or glomerular hemodynamics, because these agents cause loss of glucose in the urine. And this obligates not only loss of glucose, but sodium chloride. When these agents are given, reabsorption of glucose is blocked to the proximal tubule, and downstream, then both glucose and sodium chloride are increased. This has profound effects on kidney hemodynamics. And it turns out that those changes actually reduce something we call glomerular hyperfiltration. Now, why am I talking to CardioNerds about this? Well, it turns out when we correct glomerular hyperfiltration, there's systemic effects that are very favorable for the heart. There's a reduction in blood pressure, there's a reduction in sympathetic neural activity, there's a glucose uric effect that improves diuresis. And then systemically, there's an increase in erythropoietin, which raises red blood cells and oxygen carrying capacity. So this culminates in a number of favorable effects on cardiac function. Also, glucosuria induces a mild ketosis by increasing free fatty acid metabolism. And in a mild degree, for example, increase in beta hydroxybutyrate is a preferred myocardial fuel. So it turns out that very interestingly, these changes at the level of the glomerulus and at the renal tubules have profound effects on the systemic circulation that make heart function better. And I think this is something that's really been underappreciated is this, if you will, delicate dance between heart function and kidney function. So bottom line is lower blood pressure, less sympathetic neural activity, lower plasma volume, increased erythropoietin, red cell mass, and oxygen carrying capacity, more beta hydroxybutyrate, all of which in the setting of heart failure improves cardiac function.
Dr. Tuttle, that was so fantastic. We have this kind of message group that while we talk about the episode, and there's so many pearls that I've got to go back and listen to and that we've been pulling out here. But one thing that's really obvious is I think a lot of the time people think of, probably incorrect, definitely incorrectly, of nephrologists and cardiologists is almost antagonistic, is almost on other sides of, for example, the diuretic spectrum. But it's so cool with these SGLT2 drugs that it's really all coming together to move patient care forward. And that's really, really cool. So while these agents were first primarily used for diabetes, subsequent cardiovascular outcome trials, some of which we've already discussed, have shown improved outcomes in patients with type 2 diabetes and as well as independent of diabetes status. Would you mind discussing a little bit the background for understanding the mechanism of these medication classes? And specifically, how do they exert cardioprotective and renal protective benefits outside of their effects of glycemic control? And I know some of this you discussed a little bit, but is there anything else you think would be worth hearing for our listeners?
Well, what we're now recognizing is there are some off target effects of the SGLT2 inhibitors. But back to biology again, because that's what you invited me to talk about. One of the really interesting things is the SGLT2 receptor is only found in the proximal convoluted tubule. So the off target effects are not receptor mediated. So all of the effects I just described to you that affect kidney hemodynamics, that have systemic effects to improve heart function, are mediated by the SGLT2 receptor in the proximal tubule. So again, back to what you said, I think that what we're seeing is synergy, not antagonism in terms of both kidney and heart protection. Now, with regard to the off-target effects, what we have learned is that SGLT2 inhibitors enter a number of cells. They enter cells by non-receptor mediated mechanisms. And the cells, for example, in cardiac myocytes, when SGLT2 inhibitors enter cardiac myocytes, they actually block glucose transport into the cell by blocking GLUT1 and 4 receptors. They, in addition, reduce a signal transduction pathway called mTORC, which not only promotes inflammation, but also promotes glycolysis. So, long story short, for cardiologists, is we see a state of reduced glucose intake and reduced glycolysis, which is a relative state of cell starvation, but that's actually cardioprotective in a sick cardiac myocyte. Also, when we block mTORC with the SGLT2 inhibitor directly, there's a reduction in expression of inflammatory mediators, which is also another mechanism of progression of heart failure and cardiomyopathies. And then finally, at the level of the kidney, these changes are happening in a number of kidney cells too. So the kidney protection is, in addition to hemodynamic, these direct effects that are intracellular. And one that I'll emphasize again that's really important is the increase in hemoglobin is not a dilutional effect. It's a real increase in red cell mass. And this is because in the kidney fibroblasts, which are not the tubular cells, this is where erythropoietin is made. And it turns out in those fibroblasts, SGLT2 inhibitors actually have a stimulatory effect on a signal called SIRT1. And SIRT1 increases expression of erythropoietin. So I think it's important to recognize that the hemodynamic effects are probably predominant, but there are other off target effects in multiple cell types of the kidney and the heart that so far have been protective. That is, there's not been a side effect, if you will, or an off target effect that's been found to be adverse at the cellular level. There are some side effects that we'll talk about, but they're not related to these actions. And finally, the other reason that these are important, SGLT2 inhibitors have really been the biggest gift to date for both heart failure and chronic kidney disease. And when we understand more about how they work, we could even think about better drug targets. For example, now knowing the effects of SGLT2 inhibitors to block mTORC. Well, this gives us biological rationale to maybe just go straight for an mTORC inhibitor for subsets of patients who may progress despite the four pillars of therapy.
Dr. Tuttle, thanks for truly taking us back to the core biology from the level of the SGLT2 receptor and the proximal tubule to effects related to glycolysis to the mTOR pathway. It's really helpful to understand the potential mechanisms through how SGLT2 inhibitors exert their cardiorenal protection. And so far in this discussion, we've been really focusing in on SGLT2 inhibitors particularly, but we do know that there's agents studied in clinical trials, such as sotagliflozin, that is a dual SGLT1 and SGLT2 inhibitor. And we have recent data from the SOLOIST, WHF, and SCORE trials that showed benefit with sotagliflozin for cardiovascular outcomes. Can you tell us a little bit more about the biology of SGLT1 transporters? Where are these located? And does SGLT1 inhibition also play a role in potential cardioprotective benefits?
Yes, that's a great question. The rationale for the SGLT1 inhibition, and by the way, fluorescein, the original agent that we used in the route model, was a combined SGLT1/2 inhibitor. And the reason that we look for SGLT2 first is mainly because of the side effect profile. I'll come back to the rationale for returning to combined SGLT1/2 inhibition, but I just want to emphasize why we didn't do that first is that SGLT1 receptors are found in places besides the kidney, particularly the gut epithelium. And one of the major limiting side effects of using the agents is diarrhea, which can be quite disabling. Now, again, originally they were used exclusively in diabetes populations, and in particular, people who had kidney disease or heart disease often have gastroparesis and autonomic neuropathy. And the diarrhea that resulted with adding the SGLT1 was quite challenging for many patients. But be that as it may, there was still rationale for considering adding SGLT1 because there are SGLT1 receptors in the kidney proximal tubule, but not the proximal convoluted tubule, which is the most proximal part of the proximal tubule. So downstream from the convoluted part of the tubule, so the straight part of the proximal tubule, there are SGLT1 receptors. The rationale, again, originally came for glucose lowering because about 90% of the glucose reuptake occurs in the proximal convoluted tubule by the SGLT2 receptor, but close to 10% is mediated by the SGLT1. So the idea was, maybe you could get additional glucose lowering by blocking both receptors, and hopefully people would be able to tolerate the GI side effects. So that was the original rationale. Again, back to the first question about development of these agents for glucose lowering. But the idea then was, well, if these agents have greater glycemic efficacy, it's because there's greater glucosuria. And back to, again, the first question, the reason glucosuria is important from the standpoint of heart and kidney protection is, could we get more complete restoration or normalization of glomerular hemodynamics that then in turn would translate into even better systemic effects that flow from improving glomerular hemodynamics. So yes, in those two trials, there were favorable cardiovascular benefits. The question though is that they haven't really been studied head to head versus an SGLT2. And between trials, you really can't make direct comparisons. So I think the real question is, if there is a gain from it, is it going to be worth the side effect, particularly the management of the GI side effects?
Dr. Tuttle, thank you so much for breaking down not just the complex biological mechanisms of these drugs, but also providing some historical context to the decisions to study certain drugs prior to others. But as you've alluded to a few times, as clinicians, whenever we prescribe any class of medications, we really have to be very thoughtful of the potential side effects and what to counsel patients regarding. Dr. Tuttle, would you please be able to tell us a little bit more about the common side effects of the SGLT2 inhibitors and the dual SGLT1 and 2 inhibitors and the mechanisms behind them? And to that same point, are there certain patient populations that are at higher risk for these side effects?
Sure. And I guess just because we already started with the SGLT1, the mechanism behind the diarrhea is because there actually is less glucose reabsorption in the gut. So basically, it's an osmotic type of diarrhea, like the osmotic diuresis. So that's the main additional side effect of the SGLT1 part. With regard to SGLT2, there's some important side effects, and almost all of them relate to the glucosuria. So, most common, what we see are genitourinary infections because having glucose in the urine is fodder for bacteria and fungus. And in fact, what's most common are genital mycotic infections. They can occur in men as well as women. In women, about 4 to 5%, but in men, it's about half that, but still 2 to 3%. So all patients need to be counseled about hygienic measures. And in studies where patients have received counseling about daily bathing and clean clothes, those risks can be reduced in half. Most of the time, they're mild and we can treat through them and keep them on life-saving therapy without having to stop them. But in some cases, it may be severe, and that can be a limitation to use of these agents, especially in people who may be immunocompromised, for example. The other one can be volume depletion. Now, in our fields where we're dealing with volume overload more commonly than not, the diuresis is often a welcome side effect, but there's some patients who do have tenuous volume status. And in those people, we have to be cautious about volume depletion and might even consider proactively reducing a diuretic dose ahead of starting an SGLT2 inhibitor. And I think this brings up another issue about SGLT2s as opposed to, say, statins. These aren't really fire and forget therapies. People do need to be managed on them. And after starting an SGLT2 inhibitor, at least in our practice, we see people back within 2 to 4 weeks to recheck labs, eGFR and potassium in particular, but also a good clinical evaluation for volume status and blood pressure. And that brings up the other thing. Some people, because of the diuretic effect, can become hypotensive. And this brings up this issue of the GFR dip. So up to 30% decline in GFR is a dip that we attribute to reducing glomerular hyperfiltration, harkening back to the physiology that we talked about, in which case it's a good thing. It's actually a readout for therapeutic responsiveness. So like in DAPA-CKD and Credence, GFR dips up to 30% actually predicted benefit on kidney and cardiovascular outcomes. However, if there's more than a 30% decline, then we need to think about other issues. Usually it's volume depletion or hypotension. And most people will improve by simply backing off diuretics or other antihypertensives. Then the other big side effect that gets a lot of play is the so-called euglycemic ketoacidosis. This occurs most commonly in people with type 2 diabetes, long-standing insulin users. In those individuals, it's the glycosuria, the resulting increase in free fatty acid oxidation that leads to a mild ketosis. But in those individuals, especially with stress of acute illness, whether it's a viral infection or something else, can tip them into a ketoacidosis without severe hyperglycemia. And here, the best defense against ketoacidosis is maintaining some insulin on board. So even if they have a lowering of glucose, if you have to back off of something, you could actually reduce the SGLT2 inhibitor because the SGLT2 inhibitor benefit on heart and kidney protection is not dose dependent, but glucose lowering is. So there we recommend keep a little insulin on board and reduce the SGLT2, but keep the SGLT2 on board. It is very rare to see ketoacidosis in non-diabetic individuals. But again, even in people without diabetes, starvation, ketosis, and other things can happen, which is why we recommend these sick day rules to stop the SGLT2 temporarily during periods of acute illness. But the important thing is remember to restart because one of the problems we have with implementation of these therapies is they get stopped, let's say for an acute illness, but they don't get restarted. So we have to remember to restart these agents once a person's recovered. Usually about a week of recovery is enough and they can go back on. The other thing that came up with canagliflozin in the Canvas cardiovascular outcome portfolio of trials was an increased risk of amputation. Now that has not been seen in any of the other trials, and it may have been a play of chance. But that said, it's still good practice to remember to advise patients about good foot care. And again, this is why these are not fire and forget therapies. Part of rooming a patient on these agents should be taking their shoes and socks off. It's very simple to look at their feet. And that's why we need to do clinical evaluations as well. But with daily foot self exams and regular foot exams at clinical visits, it's very rare to see amputations. And then finally, hypoglycemia only rarely occurs. And usually this is in people with well-preserved GFR. But again, we sometimes have to back off other glucose-lowering agents. And I'll reiterate the caution if someone is on insulin to not completely eliminate it, maintain at least 10 units or so of long-acting insulin to help prevent ketoacidosis.
Wow, Dr. Tuttle, such a wealth of information there. Well, I particularly wanted to come back to that point you made about statins as compared to SGLT2 inhibitors and how these are really medications where we need to monitor patients and bring them back and do a little bit more handholding with respect to the medication. And everything you outlined there is such a roadmap to doing so that I think I might need to print it out and put it on the wall of my office or something like that. It was that incredible. That wonderful background aside, potential applications and indications for SGLT2 inhibitors continue to be areas of active investigation and recent trials examining the value of SGLT inhibitors, specifically empagliflozin with the recent IMPACT-MI trial as one example, but many others. Dr. Tuttle, could you share your perspective on next steps for investigation of SGLT2 or one, as you had mentioned already, and questions we should be thinking about as these research in this field continue?
Well, I think three things. One, I think we really need to move much more expeditiously from evidence to implementation because we have these highly effective therapies that truly do save lives, hearts, and kidneys, but they're being markedly underutilized. That's a very active area of investigation. There are multiple barriers, everything from the more complex clinical management that we just talked about to cost, to education of clinicians and patients. And the other thing too is healthcare system support for doing this kind of care, because these really aren't 15-minute visits. And we haven't really been resourced to give this more comprehensive care. And so that's a real paradigm shift. And it hasn't been very well addressed or supported, more so with perhaps advanced heart clinic programs, but not so much, I think, in general clinical practice of cardiology or nephrology. And I think this needs to be an area where we really do put a lot more emphasis and resources because people only benefit from treatments they receive, and we need to do a better job. And then with regard to implementation, you've probably all heard about the phenomenon of clinical inertia, which is where we sort of lollygag around starting these meds and trying to get them back every 3 or 4 months and start a new med. But especially if you look at the heart failure outcomes, we know that whether we look at a heart failure population or a CKD population in particular, the heart failure outcomes occur early. They're frequent in both of those populations, and we see almost an immediate benefit on reducing risk of heart failure hospitalization or urgent visits. So we can't wait 6 months to get everybody on board here. And this is, again, why it's not fire and forget therapy. We need to rapidly escalate therapies. What that means, I think it also needs research, what therapies, when, how fast. But, that is important because these patients are very high risk of death and they die of heart failure. Again, whether they come in through the heart failure portal or the CKD portal, that's what takes both groups of patients out. But they're not really both groups of patients. They're largely the same people. It just depends on which portal you come in through. So, for example, in my practice, most people have an eGFR and ejection fraction the same, both less than 30. Is it a heart failure patient with low GFR? Is it a CKD patient with low ejection fraction? Well, it's really and both. And so we need to recognize the enormous risk of death and that we have treatments that very quickly reduce that risk substantially. So implementation and then no inertia and much more rapid escalation of therapy. And then finally, back to the science again, we're learning a lot more about how SGLT2 inhibitors work and how we stumbled on this almost by accident, although not completely, because when we first gave Flores into those rats, we envisioned that at least the glomerular hemodynamic effect could occur, although I don't think we imagined it would have such profound effects on heart failure. But that said, some of the mechanisms that we're discovering really could lead us to new targets that might even be safer and more effective. So, for example, if we could target mTOR directly, then we might not have a lot of the side effects that are related to glucosuria.
Dr. Tuttle, thank you so much for noting everything that you just mentioned. I think that your points are so well taken, particularly with regards to mentioning the barriers to implementation of this science when all of the investigations are moving so quickly and we're learning so much about these drugs. I think it's really just such an important perspective to maintain that we really need to figure out how to get these medications to patients. So thanks so much for mentioning that. Now, given everything that we discussed, Dr. Tuttle, would you please be able to summarize for our audience some of the key takeaways that our listeners should remember regarding SGLT inhibitors?
Well, I think these really are transformative therapies, and they address very important risks in patient populations. For example, in heart failure, particularly with preserved ejection fraction and chronic kidney disease, which were rather hopeless conditions until these agents appeared on the scene. And now we truly have drugs that save lives, hearts, and kidneys. And I think we need to have a sense of urgency about getting all people on these therapies who stand to benefit. I also think that as we go forward, we probably should do a better job of, if you will, clinically phenotyping patients for which therapy and prioritizing those that have the greatest benefits. For example, with regard to SGLT2 inhibitors, in addition to getting them on therapy, I'd also like to comment that we should take people off of potential harmful therapies like nonsteroidal anti-inflammatory drugs and proton pump inhibitors. So please put people on guideline directed medical therapy. SGLT2 inhibitors truly have been a gift that is life saving for patients who had very few options heretofore. And also remember to get rid of the things that undo the good we're doing with these agents, such as giving nonsteroidal anti-inflammatory drugs, which are not good for either heart failure or kidney disease.
Thanks for really distilling it down to these key takeaways for our listeners and putting that clinical perspective of how to get patients on the right drugs and off of the wrong one. Something that we always like to ask our guest experts on CardioNerds is what makes your heart flutter about SGLT inhibitors and the future for science in this field?
Well, I think that the SGLT2 inhibitors really burst open an entirely new era for heart failure and CKD. And I think, as I mentioned, we have a lot to learn about how to implement and apply these therapies, how to learn from the mechanisms involved in SGLT2 heart and kidney protection to make better treatments. But the other thing it did is it ushered in a new era of interest in heart failure and CKD that's really unprecedented. And so, in addition to SGLT2, we now have other breakthrough therapies and a pipeline of therapies that may help to ratchet down residual risk. But then I just want to emphasize the other part we need to do is then figure out who gets what drug. Does everybody need everything all the time, and get rid of potentially harmful things? But what makes my heart flutter is that hopeless diseases have now become very hopeful. And these are all really good problems to have therapy so that we can even ask these questions about order of therapies, combination of therapies, phenotyping, implementations. I welcome the challenges, and I'm so glad I can go to clinic now and say, we have treatment. We have treatment that saves lives, hearts, and kidneys, and be really excited. And patients are so grateful. And especially in nephrology, many of them used to come feeling so disillusioned. And now it's a completely different vibe. And it's so wonderful to see them happy about the idea that they could actually get better, not just continue to slowly get worse.
Dr. Tuttle, your passion for the field and patient care really shines through, and it's been such a masterclass learning from you about SGLT inhibitors from the basic biology and beyond. I was just thinking back to when we first learned about SGLT inhibitors during the preclinical years of med school. And at that time, I think we just learned about it as a diabetes medication. And it's just remarkable to see that since then, there's been all of this data for the cardiovascular effects, the renal protective effects, and now it's become a pillar of therapy for both heart failure and chronic kidney disease. And it really speaks to the exciting advances in this field to how to help take care of our patients, which is the ultimate goal for all of us in both medicine and research. And it's really great to see how it can be done in collaboration with cardiologists, working with nephrologists and endocrinologists and other physicians and also other healthcare professionals. So we really want to thank you for taking out time to teach us today and really sharing your expertise. I'll definitely have to listen back to absorb all of the pearls that you reviewed and the mechanisms of action and the biology behind these agents. Thank you so much. We're really excited to share this with our listeners.
Well, thanks for including me. It's wonderful to see the future of cardiology and medicine so bright as reflected in all of you. So go forth and set the world on fire.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Christiana Dangus. I'm an intern in the CardioNerds Academy and a senior at Boston University. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.